cancers, that is unresectability. And I'm sure all the surgical oncologists, head and neck surgeons, or whosoever is operating on head and neck cancers must have faced this situation when primarily you say that the patient is not a suitable candidate for surgery. And many times you have treated the patient before with surgery, radiation, chemo, and later on the patient comes with a recurrence or residual disease, then you say it is unresectable. It is quite painful situation, not only for patient and family, but even for the medical professionals to communicate that it is unresectable and means not very many options are there. It is a painful situation, even for medical professionals. So today we'll hear from Dr. Gitanjali. Of course, the session will be moderated by Dr. Mudit Agarwal from Rajiv Gandhi Cancer Hospital. She'll talk about unresectability, and I'm sure she's going to talk about what is inoperability, what is unresectability, what are the criteria of unresectability, how do you manage, what are the options in these situations, and what are the possible outcomes. So over to Dr. Gitanjali.
Thank you, sir. Good morning, everybody. So today's class is on management of unresectable head and neck cancer. So first, before going into the management, we need to understand what an unresectable disease is. So we will understand some definitions. Resectable head and neck cancer includes any tumor that can be removed completely with adequate margins. These definitions are taken from the NCCN guidelines. Unresectable tumor is one which is associated with poor prognosis or function, or it is a T4B cancer which is technically difficult to obtain clear margins. These include involvement of the pterygoid muscles with severe trismus or pterygopalatine fossa involvement with cranial neuropathy, gross extension to the skull base with erosion of the pterygoid plates or the sphenoid, and widening of the foramen ovale indicating a perineural extension. Direct extension to the superior nasopharynx or deep extension into the eustachian tube and lateral nasopharyngeal walls, encasement of the common or the internal carotid arteries of more than 270 degrees, direct extension of neck disease to involve the external skin, direct extension to mediastinal structures, prevertebral fascia or cervical vertebrae, and the presence of subdermal metastasis. In a study by TMH, there is also a term that is defined, that is the technically unresectable tumors. I will explain more about this in the following slide, but just to understand the definition, a buccal mucosa primary with diffuse margins and peritumoral edema till or above the level of the zygomatic arch without any satellite nodules, an anterior tongue primary with the tumor extending up to or below the level of the hyoid bone, extension of the tumor of anterior two-third tongue to the vallecula, and extension of the tumor into the high infratemporal fossa, that is above the level of the sigmoid notch, and extensive skin infiltration where negative margins cannot be achieved. Now, though a tumor can be resectable, sometimes the patient is inoperable. This can be when the patient is not fit for surgery, that is, the constitutional state of health is not permitting surgery, and sometimes when adequate reconstruction is lacking or the surgery is grossly morbid. For example, bilateral orbital excentralization or excentralization in the only seeing eye, extensive mandibular resection where reconstruction is not possible, total pharyngectomy where reconstruction is not feasible. Now, according to the NCCN guidelines, any newly diagnosed locally advanced unresectable disease, that is T4B, disease or unresectable nodal disease, or when the patient is unfit for surgery, patient's clinical trial is preferred for the patient. But if definitive treatment is being planned, it should be noted that the performance score of the patient is very important to go ahead with the management. If the performance status is good, that is 0 to 1, then concurrent chemotherapy with radiation or induction chemotherapy followed by systemic therapy with radiation or radiation alone should be planned. If the performance score is 2, then radiation alone or concurrent CTRT is opted. If the performance score is not good, that is 3 or more, then palliative radiation, a single agent systemic therapy, or best supportive care is indicated. Now, what about a recurrent or a persistent disease? So, in this case, we should know whether the patient has received prior radiation or hasn't received any prior radiation. If patient hasn't received any prior radiation and it is unresectable at present, then the treatment is similar to an unresectable primary case. Whereas if the patient has received prior radiation and it is unresectable, then depending on the interval between the previous radiation, we can consider re-irradiation with or without systemic therapy, or systemic therapy alone, or if none of these are feasible, then best supportive care. Now, like in any other cancer, first staging and diagnosis is important. And similar to any other tumor, it is important to take a thorough medical history and physical examination with a note on the performance score. A biopsy from the tumor is necessary. Imaging can include a contrast enhanced CT scan or an MRI. And to assess the distant metastasis, a PET CT can be done. If not available, at least minimally a chest CT should be done. Now, we understand that the performance score is important for the further management of these patients. The most commonly used performance score is by the Eastern Cooperative Oncology Group, where the patients are graded from 0 to 5. Where 0, the patient is fully active and can carry out all the activities as before the disease. 1, where physical strenuous activity is restricted but other light work is possible. 2, when self-care is completely possible and the patient is up and about for more than 50% of the waking hours. 3, where limited self-care is possible and the patient is confined to the bed or chair for more than 50% of the waking hours. 4, patient is completely disabled and totally confined to the bed or chair. And 5 is dead. Now, coming to the specific management of these unresectable head and neck cancers. So either the treatment intent can be curative, that is definitive treatment, or it can be palliative intent. So in the definitive management, we will talk about concurrent chemoradiation, induction chemotherapy followed by definitive radiation, induction chemotherapy followed by definitive chemoradiation. And in the palliative setting, systemic chemotherapy, palliative radiation, and supportive care. So as we understand from the TNM staging, what exactly constitutes for an unresectable disease depends on the different subsites of the head and neck. For example, in oral cavity, T4B disease, that is very advanced local disease, where the tumor is invading the masticator space, pterygoid plates, or the skull base, and or encasing the internal carotid artery, is considered to be unresectable disease. Similarly, in most of the other subsites, the T4B disease itself is considered to be unresectable disease. Now, we know that the oral cavity cancer is the most common in India in the head and neck cancer. So, I will briefly discuss about the unresectable oral cavity cancer first, and then we will move on to the general management. So from the TNM staging, we understand that involvement of the masticator space is considered to be unresectable. Now, is it actually completely unresectable? So to understand this, we have to understand what the masticator space includes. So the masticator space is bounded superiorly by the skull base, inferiorly by the submandibular space and the sublingual space, medially by the parapharyngeal space, uh, anteriorly by the buccal space, and posteriorly by the parotid space. This is encased within the investing layer of the cervical fascia, and this includes all the muscles of mastication. Now, in 2007, a study by Lyo et al. Divided this masticator space into two parts with a line dividing the sigmoid notch. So they divided into a supranotch disease and an infranotch disease. It was a retrospective study with 45 patients where 38 patients had infranotch disease and 7 patients had supranotch disease, and these patients underwent resection. Now, it was very evident that the disease-free survival probability of the patients who underwent resection for infranotch disease was quite favorable. That was, it was 64.7%. Now, multiple further studies were done, and another similar study by Trivedi et al. Divided the masticator space into three parts. That is, the class 1 low masticator space, which is similar to the infranotch disease, where medial pterygoid muscle and masseter muscles and the ascending ramus of the mandible is involved. Class 2, that is intermediate masticator space, where the high supranotch where the supranotch disease was divided into low supranotch, that included the lateral pterygoid and the temporalis muscle and the lower half of the pterygoid plate. The class 3, that is the high masticator space, which included the high supranotch disease, this was involvement of the pterygomaxillary fissure and the intracranial extension. Even in this study, it was seen that the infranotch disease was still resectable, and the high masticator space disease, that is the class 3 disease, was definitely unresectable. Another study by Bhavesh Amarnath et al. Studied the infratemporal fossa clearance in 47 patients with stage T4B disease, where they excluded patients who had skull base involvement or carotid artery invasion. It was seen that almost 30% of the patients had regional recurrence or distant metastasis, whereas only 8.5% of the patients had local recurrence in the ITF. What about the compartmental clearance of the infratemporal fossa? Does this have any better clinical outcomes? A study by Rakesh Katna et al. Included patients with masticator space involvement of more than 2 of the following structures for compartmental clearance. These structures included the medial pterygoid muscle, the lateral pterygoid muscle, pterygoid plates, temporalis at the tip of the coronoid, high masseter involvement, and the retroantral fat pad. The patients who had less than 2 structures that were involved were considered for only a composite resection with wide margins, as we do usually. Patients who were excluded were patients having carotid artery encasement, prevertebral fascia involvement, and the pterygomaxillary fissure widening. This study included 54 patients, and as seen, 2-year locoregional control was 52%, 2-year disease-free survival as well as the 2-year overall survival were both 54%, with a median follow-up of 29 months. So till now, we understand that not all masticator space involvement is considered as completely unresectable. Low ITF can still be resectable upfront. Now, what about the patients who have high ITF who are considered as borderline resectable? So can we improve the outcomes of borderline resectable oral cancer by introducing induction chemotherapy into the regimen? So what is the advantage of adding induction chemotherapy? So this reduces the tumor volume, it increases the locoregional control, improves organ function, treats subclinical distant metastatic disease without any delay, and if there is favorable initial response to the induction chemotherapy, then it predicts efficacy for further functional organ preserving therapy. In 2014, a study by VM Patil et al. At EMH defined exactly what an borderline resectable or a technically unresectable disease is. So as I've already explained this, so briefly, it is a buccal mucosa primary where the disease have diffuse margin or the edema is reaching above the zygomatic arch, or the disease is reaching above the above the sigmoid notch, that is the high infratemporal fossa. And when it has come to the tongue primary, if the disease is involving the vallicula or it is reaching at or below the hyoid level, is defined as borderline resectable disease. So there, the patients received neoadjuvant chemotherapy, either a 3-drug or a 2-drug regimen. They were further assessed, and it was seen that after neoadjuvant chemotherapy, 40% of the patients became operable. And once these patients underwent surgery, they had a better survival outcome when patients who did not did not undergo surgery. Another study at TMH for long-term outcomes of NACT on borderline resectable oral cavity cancers consisted of more than 3,000 patients. They again defined the borderline resectable oral cavity cancer, and as can be seen, buccal mucosa was the most common site that was included. So these patients received neoadjuvant chemotherapy, again 2-drug or 3-drug, and it was then further reassessed, and the patients then received definitive treatment. It could be seen that 32% of the patients underwent surgery subsequently. The rest of the patients either received definitive chemoradiation or they underwent palliative treatment. In this study, it was seen that the 10-year overall survival was much better, statistically significant at 21.8% for patients who underwent surgery versus only 4.1% for patients who did not undergo surgery. Similarly, it was also seen that the 10-year overall survival for patients who received more than a 2-drug regimen for neoadjuvant chemotherapy was statistically better at 21% versus only 5.1% for patients who received only 2-drug regimen. Now, till now, we understand that some of the borderline resectable disease patients can receive neoadjuvant chemotherapy and they can be made resectable to have a better favorable outcome. Now, can we apply the same thing for unresectable oral cancer? So, is there a role for induction chemotherapy followed by radiation in unresectable oral cancer? There have been multiple phase 3 randomized control trials which included either a 3-drug or a 2-drug regime, or they received radiation or chemoradiation in the definitive treatment. But overall, it could be seen that survival benefit was not present. Also, it was seen that the patients who received neoadjuvant chemotherapy had worse toxicity than patients who received only definitive treatment. So, neoadjuvant chemotherapy does not have a definitive role in frankly unresectable oral cavity cancers. Now, induction chemotherapy does not have only a role in borderline resectable. Certain other tumors like advanced laryngeal, hypopharyngeal cancers which are unresectable and they require organ preserving therapy, they can also need induction chemotherapy. Nasopharyngeal carcinoma also has a role for induction chemotherapy. So now coming to general treatment. The role of induction chemotherapy in unresectable head and neck cancer has been studied in the 2 phase 3 trials, that is the TAX 323 and the TAX 324. The TAX 323 had 2 arms of study. The first, the 3-drug regimen, including taxane, platinum and 5-fluorouracil, and the second arm being the 2-drug regimen, that is platinum and 5-fluorouracil. After after the neoadjuvant chemotherapy, these patients received radiation only as the definitive treatment. Also, the primary endpoint in these patients was progression-free survival. From these Kaplan-Meier curves, it was seen that the median progression-free survival as well as the median overall survival were both statistically better when 3-drug regimen was used when compared to 2-drug regimen. Later, the tags 3 to 4, similar 2 arms were used with 3-drug and 2-drug regimen, but the doses were increased in these arms. And the other difference in this trial was that along with radiation, chemotherapy was added in the definitive setting. That was carboplatin AUC was added 1.5 weekly. Also, another difference was that the primary endpoint here was considered as overall survival. Again, in these Kaplan-Meier curves, it was seen that the median overall survival as well as the median progression-free survival was statistically much better at 71 months versus 30 months for median overall survival when 3-drug regimen was used for neoadjuvant chemotherapy when compared to the 2-drug. Similarly, progression-free survival was also significantly better for the 3-drug regimen at 36 months versus 2 drugs for 13 months. So till now, again, we understand that if neoadjuvant chemotherapy is required, then a 3-drug regimen is better than a 2-drug regimen. Now, we understand that for definitive treatment of the unresectable head and neck cancer, radiation has a better curative intent. Now, does addition of chemotherapy add to the favorable outcomes of the radiation therapy? Yes, it does. So what about the optimal timing of the chemotherapy to be added to the radiation? So this was analyzed in the McKenzie meta-analysis, where all 3 types, that is the induction chemotherapy, the current chemotherapy, as well as the adjuvant chemotherapy, was studied with when the patients received radiation. So in this, it was seen that the event-free survival was much better when patients received concurrent chemotherapy with a hazard ratio of 0.8. Similarly, the overall survival was also much better when the patient received chemotherapy in the concurrent setting when compared to induction or adjuvant setting with a hazard ratio of 0.8. It was also seen that the absolute benefit at 5 years was 6.5% and the absolute benefit at 10 years was 3.6% when concurrent chemoradiation was compared with radiation alone. So with this, it could be inferred that with radiation, concurrent chemotherapy is better than induction or adjuvant chemotherapy, and concurrent chemotherapy is better compared to radiation alone. In certain subsets of this meta-analysis, it was also seen that the addition of chemotherapy may not be beneficial in patients with performance status of 2 or more and age of 70 or more years. So now we understand that concurrent chemotherapy concurrent chemoradiation is the treatment of the first treatment line for unresectable head and neck cancer. So what is the choice of chemotherapy that can be used? In head and neck cancer, cisplatin is always the first line of therapy. What about the dose of cisplatin and what about the role of cetuximab? The role of cetuximab was studied by Bonner et al., where they had 2 arms in the study that included radiotherapy alone and radiotherapy along with cetuximab. So it could be seen that the loco-regional control was significantly better when cetuximab was added to radiotherapy with 24.4 months of loco-regional control, median loco-regional control, whereas radiotherapy alone was lesser. Overall survival also was similar, where cetuximab addition to radiotherapy had significantly better median overall survival when compared to radiotherapy alone. The limitation of this study was that cetuximab was not compared with cisplatin, which is considered as the first-line chemotherapeutic drug. In RTOG 1016, cetuximab was compared with cisplatin when given along with radiotherapy. But this study was specifically done in HPV positive oropharyngeal cancer for de-escalation therapy. But still, it was seen that cetuximab had an inferior progression-free survival and overall survival when compared with cisplatin. Now, what about the dose of cisplatin? So the standard dose for cisplatin is 100 milligram per meter square 3-weekly dose. But this dose is quite toxic, especially nephrotoxicity is quite high. So there have been studies to evaluate whether an alternate dose can be given instead of 100 milligram per meter square 3-weekly. So a study at TMH studied cisplatin 100 milligram per meter square 3-weekly versus 30 milligram per meter square weekly. So in this, it was seen that the loco-regional control was inferior for the weekly 30 milligram per meter square arm versus the 3-weekly arm. But it was also seen that the progression-free survival and the overall survival was not different in the two arms. Another study where cisplatin 100 milligram per meter square 3-weekly was compared with cisplatin 40 milligram per meter square weekly. There is no complete paper available, but the abstract was published in the ASCO 2022 meeting. This study was a phase 3 randomized control trial done at AIDS. So in this, it was seen that the 2-year loco-regional control rates was 52.6% when cisplatin 40 milligram per meter square was used versus 47.4% for 100 milligram per meter square cisplatin used. So it could be seen that the weekly 40 milligram per meter square was non-inferior to the standard 100 milligram per meter square. Also, there were lesser treatment interruptions, lesser hospitalizations, and lesser side effects like mucositis, myelosuppression, and renal toxicity. So what about the radiation therapy schedule? This was evaluated in the March meta-analysis for radiotherapy fractionation in head and neck cancer. There are multiple studies in this meta-analysis, which I will not go into detail about. Overall, it could be seen that the hyperfractionated radiotherapy is the standard of care in concurrent chemoradiation setting. It has a superior overall survival, superior loco-regional control, and though the acute toxicities are higher when compared with conventional radiotherapy, the delayed toxicities are still similar. It could also be seen that the absolute benefit was 8.1% at 5 years and 3.9% at 10 years when hyperfractionated radiotherapy was utilized when compared with conventional radiotherapy. So now, till now, we have spoken about the definitive management for unresectable head and neck cancer. Now, what about patients who cannot undergo definitive treatment? So those patients will need to go palliative intent of therapy, and that is similar to advanced or metastatic head and neck cancer. So to understand this, there is a simple algorithm. First, we have to know whether the patient has received any platinum-based chemotherapy within the last 6 months. So if yes, then the options include a single-agent pembrolizumab or nivolumab, and if not, then PD-L1 CPS score is evaluated. If the CPS score is more than or equal to 1 and the patient has rapidly progressive disease, then the patient should be opted for chemotherapy along with pembrolizumab. If there is no rapidly progressive disease and the CPS score is more than or equal to 20, then single agent pembrolizumab is sufficient. If not, then consider chemotherapy with pembrolizumab. If the patient is not eligible for a combination of chemotherapy along with immunotherapy, then single agent pembrolizumab should be considered. If the CPS score is less than 1 and the patients have good performance status, then chemotherapy with pembrolizumab or with cetuximab should be considered. If the patients have poor performance status, then either a single agent therapy or best supportive care is the option available. To understand the role of pembrolizumab, Keynote 048 had 3 arms, that is the pembrolizumab alone arm, the pembrolizumab along with the chemotherapy arm that included carboplatin or cisplatin with 5-fluorouracil. These were compared with the extreme regimen. Extreme regimen included cetuximab with carboplatin or cisplatin. The primary endpoint of this trial was the overall survival. So overall, we can understand from this table that whether PDL1 CPS score of more than or equal to 20 or PDL1 CPS score of more than or equal to 1, both have a better overall survival when pembrolizumab was added to chemotherapy or with pembrolizumab therapy alone when it was compared to the extreme trial. But specifically for PDL1 CPS score of more than or equal to 20, the pembrolizumab single agent had a slightly better trend for overall survival, whereas for PDL1 CPS score of more than or equal to 1, the pembrolizumab along with chemotherapy had a slightly better trend. Now, if the patient cannot undergo systemic therapy, that is systemic chemotherapy or immunotherapy, then the other choice is oral metronomic therapy. Oral metronomic therapy, that is a study by in TMH by Patil V et al. Was a randomized phase 3 trial where oral metronomic therapy that includes methotrexate and celecoxib was compared with cisplatin alone. The overall survival was the primary outcome. So in this, it could be seen that the 6 months overall survival was 62% when OMCT was given versus 51% for cisplatin alone. And the 6 monthly PFS, that is progression-free survival, was 27% for OMCT versus 8% for cisplatin alone. The same can be seen in this Kaplan-Meier curve. So the oral metronomic therapy had better outcomes when compared to cisplatin alone. Now, what is the role of a surgeon in unresectable head and neck cancer? So, there are multiple complications that patients come when they are either on chemotherapy or definitive treatment, such as airway compromise, bleeding, infections, dysphagia. So, these can be managed by the surgeon. So, airway compromise, specifically when cancer related, they can be because of the advanced tumors themselves due to direct mechanical obstruction. It can be due to secondary to hemorrhage, secondary to infection, post chemoradiation edema, aspiration, or metastatic disease compressing the airway. The airway compromise can be either acute or it can be chronic. Depending on the type and the cause for the airway compromise, management can include stabilization of the patient with oxygenation, giving steroid and nebulization, intubation if it is feasible, or tracheostomy either in the elective setting or at emergency setting. In such patients, dysphagia can be due to again multiple reasons. Either the patient can have dysphagia due to the tumor directly, either due to compression of the alimentary tract, or it can be due to the narrowing of it. It can be due to the sequelae or the side effects of systemic therapy or radiotherapy. So in these cases, the management has to be uh, along with a speech and swallow pathologist. It should include oral hygiene, the management of the side effects that include management of xerostomia, like giving artificial salivary sprays, treatment of mucositis and edema. In this, infection also has to be controlled, like candidiasis, management of the dyselectrolytemia, uh, and also specifically to the dysphagia, either enteral feeding using a nasogastric tube or a percutaneous endoscopic gastrostomy or a feeding jejunostomy can be considered, or parenteral feeding can be considered. Now, vascular complications, the causes can be rupture or injury to the vessels. This can be due to weakening of the vessel wall, degradation due to the salivary leak, or tumor infiltration into the vessels. Directly, the tumor bleed can also be there. So, management, as usual, first the airway management and the resuscitation is important. Blood transfusions may be required. Also, specifically for the management of the bleeder, if the institute has an interventional radiologist, then CT angiography along with embolization can be considered. If not, then exploration with the ligation of the specific vessel or the ECA may be required. Now, no matter what the definitive or the palliative treatment is, this has to be supported with supportive and palliative care, which is a multidisciplinary team involvement. And the domains of palliative care have already been explained in the last class. So this is also important at every stage of management for an unresectable head and neck cancer. So take home message, it should be understood that when the patient comes to the OPD, it is important to understand whether the treatment options are curative or it is a palliative intent. For this, performance status is important. Also, masticator space involvement, though considered unresectable, now is maybe resectable, especially the low ITF region. The borderline resectable oral cavity cancer now can be considered for neoadjuvant chemotherapy and then definitive treatment, where surgery is preferred if it is feasible. And unresectable head and neck squamous cell carcinoma, the definitive choice of treatment will be concurrent chemoradiation. If this is not an option, in palliative setting, chemotherapy with or without immunotherapy and oral metronomic chemotherapy is an option. Also, palliative and supportive care is a constant no matter what the treatment. Thank you.
Thank you. Dr. Mudit.
Yes, sir. So I think Dr. Gitanjali has beautifully summarized the unresectability in head and neck cancer. So what I say is, before labeling the patient unresectable, one should be very sure, because you are labeling the patient unresectable, and patient goes for alternate modality of treatment. So before, if any, you see a report of MRI or CT scans saying that there's an inflatable fossa involvement in oral cancer, please redefine things, whether supranodous disease or infranodous disease. So we know that in NCCN, T4B masticated space comes there. They have not changed it. Might be in subsequent TNM, we might have a different definition of T4B. But presently, T4B in oral cancer, masticated space involvement is there, and has been shown in 2007 that infranodous disease behaves as T4A only. And we have been operating doing that. So one need to define that. So if you have inflatable fossa involvement, one need to classify supranotch and infranotch, where you can definitely go for a surgical intervention in first setting. Secondly, I would like to say that these patients who are having supranodal disease needs to be further defined. You can go for systemic therapy, but all these things management has to come in a multidisciplinary mode. Means it is not the surgeon's purview. You have to discuss with your colleagues, medical oncologists, radiation oncologists. So what will be the best treatment for these patients? So because these patients doesn't have very good outcome, so we have to take care not only of the prolongation of life, but the quality of life also comes into picture. So here, what as told that we have to take care of their feeding, whether patient is in dysphagia or not. These things need to be taken care of. Pain management also comes into play because these patients will be having terrible pain. So pain and palliative care becomes really a good component when managing these patients. So that's what I want to say, that these patients being unresectable, we need to define them, and these patients can be taken care of with multidisciplinary approach. Thank you, sir.
I fully agree with you, Dr. Mudit. I think decision making is extremely important. When to intervene, particularly in recurrences or unresectable tumors, is important.
Right.
And number two, I think as a surgeon, everybody should know whenever you are doing a redo surgery or surgery in an irradiated patient, be very, very careful. Take the help of your colleagues, help from your seniors, help from the reconstructive surgeons, because these are not easy surgeries and not for first timers.
That's true.
Like if radical dose of radiation has been given before and you are going to operate on this patient, you should know that you are going to cover that area with non-irradiated tissue so that proper healing can occur. So few precautions you have to take whenever you are operating on such patients. And you need to counsel the patients about the possible outcomes also. They become very hopeful कि डॉक्टर साहब दोबारा से सर्जरी कर रहे हैं, अब तो ठीक हो जाएगा. So as you said, that the duration of disease-free survival is important. What time you are going to intervene, re-radiate or redo surgery, those are important, and accordingly you will counsel the patient. Okay. And I think OMCT plus minus low dose immunotherapy, have you covered?
Yeah. She talked
No,
about
sir, but there is another TMH paper
study. Yeah.
which suggests that low-dose nivolumab has good outcomes when given with oral methods.
And the outcomes in these unresectable head and neck cancers. The outcome and the management in, say, laryngeal cancer, maxillofacial cancers, oral cancers will be entirely different.
Yes.
So, as a surgeon, I think you should know about all these. और डॉक्टर मुद्दित और कुछ ऐड करेंगे?
Sir, I think that resectability, because we have talked majorly about oral cavity, about if you say for larynx, so there also we say unresectable because we have a doubtful pre-vertebral invasion or we have ICA involvement is there. Then they have explored in TMS the role of neoadjuvant chemotherapy in these patients. But really the role is not well defined. So in these patients where I have a doubtful resectability on your imaging as well as clinical examination, then one should not jump straight away into surgery. You should take the help of neoadjuvant chemotherapy and then followed by assessment of those patients.
I fully agree with you. Well done, Dr. Gitanjali. Very well done.
Thank you, sir.
Well done.